Hi, everybody, and welcome. My name is Jen Elder. I'm the director of the Homeless and Housing Resource Center, sponsored by SAMHSA. I am so excited that you are joining us today for the second part in our webinar series on psychotic disorders. And today is going to focus on outreach and housing support for individuals with psychotic disorders. So we'll go to the next slide to get us started. Just a quick disclaimer from me, we are funded by the Substance Abuse and Mental Health Services Administration, but all of the views expressed today are not necessarily the official opinions or views of SAMHSA or HHS. Next slide. As you can see, we are so thankful to be joined by American Sign Language interpreters today, as well as a live human captioner. So if you need closed captions on your screen, you should be able to turn those on. If you have any technical difficulties during the webinar, please feel free to reach out to us via email or using the Q&A feature. Myself and our team monitor that in the back end and can help troubleshoot. Next slide. So just a few housekeeping items from me. We are going to be joined by a large group today. We are very excited about that. But with that, all the participant lines will be muted and the chat feature is disabled. But that said, we do want to hear from you. So you have the Q&A feature at the bottom of your screen. That's where you can reach out to us, submit your questions, and we're going to try to answer as many as we can. Something we're really excited about today is we received over 1,000 questions in advance during the registration. And so we have organized those, provided those to the panelists today. And so we're going to be framing the discussion based on all of the great questions you asked in advance. So not as many slides today, more of a great group discussion about evidence-based practices. So, but keep your questions coming during the webinar and we'll address as many as we can. The slides are available now on our website. We just have the link was just posted in the chat. We'll have a recording available on our website within 1 week. At the end of the webinar, there'll be a link to an evaluation. It's pretty short. And at the end of that, you'll be directed to a certificate of participation. We don't provide any CEUs, but you may submit that certificate to your licensing board if you'd like to get CEUs for today's session. Next slide. All right, with that, we have a tremendous panel today. I will welcome Gordon Shen he will be the moderator of today's session. And so each of the panelists will get to introduce themselves separately. So with that, I'm gonna turn the session over to Gordon.
Thanks, Jen. Hi, everyone. Thanks for joining us today. My name is Gordon Shen. I'm an assistant professor of healthcare management at the University of Texas Health Science Center at Houston School of Public Health. And I'm joined today by an esteemed panel of experts on precisely the topic on housing and outreach support on psychotic disorders. So you're in for a treat, as am I. As Jen had mentioned, I'll let the first segment of the webinar today is me letting each of the panelists introduce themselves to you and how their work relates to the topic today. So without further ado, I'd like to turn the floor to Dr. Anna Turner. Anna?
Hello, thank you so much. I'm really excited to be here. I do have a few slides just to describe what I do. I'm a psychiatrist, you can go to the next one, with the Sulzbacher Center and the University of Florida. We're located in Jacksonville, Florida, and this is a picture of our shelter. We have also on site a federally qualified healthcare center, FQHC. That's kind of in the bottom right of that picture. So we have a full array of services, and I'm really happy that I get to work there. The next slide talks about various services we have at our healthcare center. We have primary care, dental, vision, mental health, substance abuse care. We have 4 locations. We also provide street outreach that I'll talk a little bit more about. We can get people free medications there. We can get all kinds of other housing and case management services, as well as we have some school-based clinics, a medical respite unit, and then a mobile health unit where our primary care providers can actually go do exams on the streets. So the next slide talks about a little more about our street outreach. We have 2 case managers that go out every day and look for people on the streets. And when they identify a need, they can bring out a medical nurse practitioner to do diabetes, high blood pressure management, or they could bring me out to do psychiatric services. So we'll play that till just about 1 minute and pause it there.
Y'all like something to eat and something cold to drink? Keith Brown. I've been on the HOPE team in the downtown area for 19 years. We started in 2000. Dr. Christensen was my best friend, my worker, who worked along with me, my partner. He was my everything. When we first started, the homeless outlook downtown was very serious. You could ride around in the morning coming to work and there would be people sleeping all in different doorways.
Okay, so what we do on the Hope Van is we provide medical services for the streets. We pretty much take it right to them in their elements. Medical, psych, we have food, clothes, and we try to help them get off the streets if they're ready to get off the streets, but we kind of work at their own pace and we kind of bring it to them. So that's pretty much what we do.
So we can pause it there. So then the next slide, that's one alternative we have for getting people care in our city of Jacksonville. This is just a picture I took when I was walking past a business that said, "Keep your money, don't support vagrants and panhandlers. Call 911 if you feel threatened." So, unfortunately, we're seeing in society that they don't, feel comfortable being around people and maybe would rather call 911. And what we found, one study in Osceola County just looked at people who keep getting arrested over and over for loitering or trespassing, misdemeanor crimes, or hospitalized for chest pain or suicidality. We spend $31,000 per person per year to keep them in that system. Whereas if we could put that into HUD or Section 8, it would be more like $10,000 per person per year. So on our next slide, you'll see the astounding amount of people we arrest in the US, as well as particularly where I work in Florida. And, it's incentivized. We have people making money off of arresting people because our jails and prisons are privatized. So Gordon's going to take you to he'll stop sharing and then share a video of another alternative that we have that I'm proud to be part of called the Mental Health Offenders Program, where we can do something about that. And I get to be part of that as their psychiatrist.
Costs for each misdemeanor arrest in Duval County. That's enough to put someone in housing for a month. This program targets people who've been arrested dozens of times. Organizers say keeping these offenders out of jail ends up saving taxpayers a whole lot of money.
All right, ready.
On a mission, these mental health professionals are hoping to solve some of Jacksonville's problems with homelessness and drug use, one person at a time.
The Mental Health Offenders Program has just been life-changing for so many people who are just stuck in this cycle of repeatedly getting incarcerated or repeatedly getting hospitalized.
Turn left onto West 27th Street.
James is a good example.
This team of a psychiatrist and social worker from the Sulzbacher Center is visiting a military veteran who'd fallen on hard times, struggling with substance abuse and schizophrenia.
I had problems with mental health, but I had to go to the hospital.
James spent much of this past decade without a place to live and without appropriate treatment, a downward spiral that resulted in petty criminal charges again and again. How many times have you been to jail?
10 times.
10 times. What was that like?
Bad.
Yeah. What'd you get arrested for?
Trespassing, violation of probation.
His life started to turn around when local mental health workers saw him at the jail as a prime candidate for a new pilot program called the Mental Health Offender Program, or MHOP.
So initially for the pilot, we created a list. So on that list, we had about 220 names.
Dr. Colleen Bell is the lead psychiatrist for the program, which she helped create. Her team works with police, prosecutors, public defenders, and judges to identify people who need mental health and drug treatment, not a sentence behind bars.
We were targeting misdemeanor offenders, so people that had severe mental illness, as well as crimes like trespassing, your more nuisance crimes, you know, the people that we all agree don't belong in jail. They're not your career criminals. They're not violent. We've been able to help individuals. One individual was in jail on average every 10 days.
James went through the program and is now in aftercare. As part of that, he must continue to check in with the team, stay drug-free, and get those injectable medications to help manage his conditions. The social workers are helping him get his Social Security, as well as his veterans benefits and other welfare.
Hey, Magistrate Bree.
How are you doing?
I'm all right.
A big component is court. Magistrate Brooke Brady and another judge handle the MHOP program at the Duval County Courthouse.
So how's everything going on your own? I hear you're doing well.
They make sure that participants follow the rules and get the help that they need.
You've been doing okay?
Yep.
I heard you were negative on your drug screen. That's fantastic.
We watched your hearing. You show.
Great. So, so that's just an example. We'll just end it there so you don't have to see the whole thing of a program that is working in our city. And so my last slide is just a quote I really like to use in my work, that, you know, there's a lot of things people are going through on the streets, and the ultimate measure of health in any community might reside in our ability to stand in awe at what folks have to carry, rather than in judgment at how they carry it. So that's about me.
Thanks, Anna. And yeah, so like a wonderful showcase of what you're working on over there in Florida. And now, you know, we'll turn from Jacksonville to the Dallas-Fort Worth area and hear from Joel. Joel?
Hey, super happy to be here. And I'll just give you a kind of a quick rundown. I don't have slides with me, but I just want to make it kind of quick about what I do. I'm a PA, and I'm the director of the street medicine program here in Tarrant County in Fort Worth at the JPS, John Peter Smith Health Network. And it's the publicly funded system here for the county. This may be the sister to Parkland for Dallas County, if some of you are more familiar with that. And I work actually in a small team with myself, a social worker, a nurse, a community health worker, and a mobile health coordinator who's also a community health worker. And we provide primary care on the street to people experiencing unsheltered homelessness. And that is anywhere in the county. And we go to places that you might think, under bridges, encampments, abandoned, safe abandoned buildings, and places not meant for human habitation. And then other places that maybe aren't so, aren't quick to come to mind. Sometimes we go into the jail, sometimes we go temporary lodging of people that are temporarily lodging in apartments, or hotels is a common one. Anyway, we kind of go wherever our patients are and try to meet them in their reality, both literally as well as figuratively. And then we try to provide the wraparound services that we can provide. And absolutely, we're just one member of the community that it takes to help somebody exit unsheltered homelessness. And so we work really closely with our mental health organization locally called MHMR, and other housing outreach organizations and shelters. And so we, though we're not necessarily physically or financially part of any of those teams, we work extremely close together, similar to, I'm sure, most, if not all of you all have it in your communities. So what we do on a day-to-day basis is we go to our people our patients that we know where they're theoretically know where they're at, and provide primary care services. A lot of follow-up, a lot of checking in, helping coordinate services with some of those other agencies, and then within our own system. I feel like one of the biggest things that we offer is just help navigating the healthcare system. As you all know, probably professionally in your roles, but also probably personally, that the healthcare system can be such a daunting institution to navigate, and that is a big role that we play from a healthcare delivery perspective. What we do is try to provide good, excellent primary care of chronic complex diseases, lots of wound care. We carry some medications with us, primarily to treat infectious diseases, acute care kind of treatment, do minor procedures on the street. Some focus areas for us, in addition to the complex chronic disease and preventive care, is hepatitis C screening and treatment on the street, PrEP, pre-exposure prophylaxis medication to help prevent the spread of HIV, and as well as medication-assisted treatment such as Suboxone on the street as well. And then we do a fair amount of, I call it primary care plus level of behavioral health and psychiatry. And again, that's where some of the treatment that we can provide on the street, and then the patients that need more care than we are trained to provide, we coordinate with some of our own behavioral health services, as well as the other services in this county. And then we also have some sports medicine presence, where with so many musculoskeletal complaints, that has been a fantastic addition to our team, is to have some sports medicine providers, attending physicians come out with us and see patients on the street. Another big component of what we do is teaching. So we have a street medicine track for the family medicine residents here at the JPS Family Medicine Residency. And that's a 2-year track for their second and third year. They could stay and do a 4th year in street medicine if they want to. Currently, we have 13 residents in the track. We also have a street medicine fellowship, and we'll be starting with our new fellow next week. And that's a 1-year fellowship. And then we have rotations for medical students and other residents to do 2 or 4 week rotations with us, where they can get a better appreciation for homelessness in its broader context and all the challenges that are in place, and see, up close and experience as much as that level of experience can provide what maybe their current or future patients might be dealing with. So that's a quick overview of what I get to do here in Fort Worth and Tarrant County. So I look forward to talking with you all more.
Hey, thanks, Joel. So, this panel is very interdisciplinary. And so we've heard from Dr. Turner, who was trained in psychiatry, and now Joel, who is a physician assistant. So next we'll turn to Wayne, who is a top manager with the Harris Center. Wayne.
Good afternoon. I'm Wayne Young. I'm the CEO of the Harris Center for Mental Health and IDD. I appreciate the opportunity to be with you here today. I also, by training, am a licensed professional counselor and also a person with lived experience. I'm in long-term recovery. So I just wanted to take a couple of minutes by way of introduction and talk about the Harris Center and some of the components and programs that we have that support individuals who are experiencing homelessness. Angela is going to do a great job talking in depth about our behavioral health response teams, and so I won't do anything that steals her thunder. I probably couldn't anyway, to be honest. She's spectacular. But the Harris Center is the community mental health center, the local mental health authority, the services board. There's lots of different names for us around the country. But if you've got a public safety net mental health system, that's who we are for Harris County and the city of Houston. Harris County is the third largest county in our country. The city of Houston is the fourth largest city. Our population in my catchment area is almost 4.9 million people, a little over 4.8 million people. We have 2,700 dedicated employees who served almost 90,000 people last year with a little over 1.9 million services. So we're a large behavioral health and IDD agency, relatively so because of the population size and the urban density that we have here. And if you think about our programs, we really significantly evolved into partnership with the homeless service delivery system as a result of our first effort at a diversion center. Some people might call it a deflection center. It's a 36-bed pre-charge mental health jail diversion center, meaning law enforcement can bring people to us 24/7 prior to charging them so that they don't end up in the jail. And these are people with mental health conditions, history, or obvious presence, exclusively for misdemeanors. We have diverted on average about 1,500 people a year from jail over the last 5 years. So I think last count, we're a little over 7,700 diversions that we've had over the last 5 years. What we found in that process is that between 65 and 80% of those individuals that are diverted on any given year are experiencing homelessness. So that connection point brought us in close contact with the homeless service delivery system and then began to blossom and grow from there. So in addition to that entry point, if you will, almost, we have homeless outreach teams. We have about 60 different kinds of response and outreach teams across our community. Some are triggered by 911, some are triggered by 988 or the hotline in our area. Some are as a direction of virtual programs where we respond virtually to people with law enforcement officers with tablets in their car. But we have a specific team with Houston Police Department where we go out, do proactive outreach and response kinds of engagements with individuals experiencing homelessness through the dedicated outreach team, all sorts of direct service delivery, referrals, connectivity, traditional engagement activities as well. We also have in our community a recently opened navigation center where we've embedded behavioral health staff as a part of that navigation center to be able to connect with individuals, help them identify needs that they might request services for, connect them to services, be that service delivery arm. So that team is there, not quite 24/7, but nearly around the clock. The navigation center does tremendous supports and services on initial. And then there are times where individuals arrive at the navigation center and we identify that their mental health needs are more significant, then we can meet there on site. And so we serve as a conduit to escalating oftentimes additional services, whether that be at the diversion center, whether that be at our psychiatric emergency center that we operate, inpatient care, whatever that might look like. As we grew from that, we ultimately ended up at the request and to some degree the funding of the city and the county. We acquired a property. It was formerly a hospital. It's 108 beds. And it is what we refer to as the Respite Rehabilitation and Reentry Center. So these are 108 beds that serve multiple programs that serve individuals that are all at the intersection of criminal justice involvement, serious mental illness, and experiencing homelessness. So there is everything from hospital to homes, which are basically rehab step-down beds for people coming out of inpatient stabilization that are experiencing homelessness. We relocated jail diversion there so that we might kind of centralize. We have a state hospital step-down program for people that have been in the state hospital for more than a year and don't have any kind of stable housing to transition back into the community with. We have a small detox and residential program for substance use disorder for individuals experiencing homelessness. So a variety of different programs that are, we have a jail reentry beds. We got about 20 jail reentry beds for individuals leaving the county jail who have a mental illness, who are experiencing homelessness as well. So kind of multi-programs to be able to impact individuals at several different kind of intersection points, if you will. And with that, I'll end up letting Angela talk more about our behavioral health response teams and her role in that. But that's a little bit about the Harris Center and the work that we do.
Thanks, Wayne. Yes, and like Wayne said, next we'll turn to a colleague of his, Angie Shoemake, a peer support specialist, also at the Harris Center.
Hi, thanks for having me here today. Apologize for my voice. I have a sinus thing happening. My name is Angela Shoemake, and I am a peer specialist at the Harris Center, as Wayne so kindly introduced me already. I do work for the behavioral health response team. We do have 3 teams here at the Harris Center. I am currently the only peer specialist assigned to work for all 3 teams. What a peer specialist is someone with lived experience who's in recovery. Mine is in mental health. And we are a city-funded program. We get our referrals directly from our housing partners. And then those referrals come in to our teams, which have a master clinician and either an LPC or an LCDC, and then me as the peer specialist all on board on the team. And then the care coordinator decides whether or not that particular client would benefit from peer services. And at that point is when I would go out. What our team does is it's a 90-day short-term safety net program. It's fully designed to identify and fulfill needs of some clients who maybe need more intensive care and hand-holding or just more support to kind of guarantee that their housing needs are going to be met and that they don't have any other significant needs that are getting ignored or neglected, whether it's medical or psychiatric care and medications, income support, or other things in the community. Our goal is really to assist our clients in getting out of surviving mode and getting to thriving mode, getting them to a point where they feel like they are in recovery and in control of their lives. Peer support specifically helps build a quick rapport and decreases barriers to services, because I am going out in the community into our clients' homes and meeting with them there where they're more comfortable. And with my lived experience and sharing my own recovery journey, it kind of breaks down and builds trust, breaks down those barriers and builds trust with them over a shorter period of time. And the best thing about a peer specialist on your team is really that we provide a truly trauma-informed approach using inclusive, non-judgmental attitudes, because we've been there, so we have no place to judge others. And it really helps our clients really open up and talk to us about what their needs truly are. And then what it looks like on a day-to-day basis is I may be helping someone go over coping skills that their therapist is working with them. I might be giving them a ride to the food pantry or dropping up a food pantry emergency food donation so that they have food through the weekend. I might giving them a ride to Operation ID because they don't have Texas ID and it's stopping them from being able to access other programs in the community. I might be pulling up information on other community programs that maybe we aren't directly partnered with, that they do have access to, and make sure that they have that information so that they can go forward. And I also do advocacy and also help model and teach them how to be advocates for themselves as they go through these various systems that are very complicated and sometimes very stressful and foreign to them. And just really help them have all the tools on board to maintain their housing and not end up back out on the street and just go on with their lives and get to where they want to be in their recovery journey. And that's a little bit about me. Thank you.
Thanks, Angela. And last but not least, let's hear from Dr. Laura Marsh. Oh, sorry, Laura.
Not on, I got it. Yes.
Yep.
I'm Laura Marsh. I'm a psychiatrist, a geriatric psychiatrist and neuropsychiatrist who's the executive director for the mental health care line at the Michael E. DeBakey VA Medical Center here in Houston. And in terms of what we have a large VA, just like Wayne was saying, here in Harris County. We cover about 23 counties, and we're covering from north of East Texas down to the Gulf Coast. Every year we see about 110,000 veterans, but about 40,000 or so are in the mental health care services. A large portion of those are also receiving homeless services. And we have a medical team that works with the larger homeless program, which is largely made of social workers and outreach workers with them. Where I'm involved with the homeless has really been in helping to mobilize our VA resources and to also look at sort of things that we haven't been able to accomplish. So our town is wonderful in terms of how it's been able to address homelessness in a very proactive and collaborative way as agencies. When we still have a number of individuals who are sort of most challenging or vexing in terms of what the solution is. And so I'm part of a work group that's looking at how these agencies across systems can work together better. And we have a group of patients who we've all identified from each of these groups. Mine, of course, would be someone from the VA. Others have non-veterans, so I'm involved in the care specifically of veterans. But our veterans are eligible for care at many other locations. So what we find is that my patient from the VA might also be accessing all the other services throughout our Harris County. And yet we still, after 62 admissions, for example, to our inpatient units or our medicine services, they're still not living in permanent housing. And their psychiatric condition or substance use disorder or combination are still active. And what do we need to do in that circumstance to try to work together? In today's conversation, I think that maybe some of the things we speak about in terms of working with people who have psychotic disorders. There's also a question I think that referred to, what about if there's other interpersonal difficulties that an individual has? And what we've kind of come to the conclusion is that each of these individuals who are in this sort of vexing or challenging category are people who, regardless of their psychiatric condition, they do have problems with accepting and receiving and staying engaged with help, but also they seek help at the same time. So there's kind of that ambivalence. And so we're working on ways that we can, as a system, address that. So in concluding, I think what I want to say is I just want to thank everyone who's here. I see there's over 2,000 participants, and you folks who are out there, truly on the streets in doing the street medicine, providing this direct care. I really want to thank you. You are real heroes to me, and I value so much of what you do. So I'll stop there. Thank you.
Thanks, Laura. And I would second that. Yeah, thanks for all the wonderful work that you're doing and for joining us today. So after this round of self-introduction, I want to take some of the wonderful questions that you posed to us when you register, and in turn ask them to our group of panelists. So one of the most common questions we received, at least in the registration side, is what type of housing options exist for someone who experiences psychosis? And related to that is, how do you determine the fit, and how do you go about enrolling them into these various housing options? So I'm sure I'm not sure if Angela, Joel, or Wayne, you'd like to weigh in here on housing options and enrollment.
I can talk about what happens at VA level, but I think
Sure, yeah. If you wouldn't mind starting us off, Laura, Please.
So a little more, and it's important, I think, for everyone who sees individuals to always ask if that individual served in the military. Many people don't recognize themselves as veterans, but they may have served, they see themselves as serving in the military, and then you may be able to identify that they are a veteran, that they're eligible for additional services. And they've broadened the categories of veterans who can actually benefit from veteran-specific services. So if they don't have an honorable discharge, but something other than that, they can now get certain levels of services. There are other individuals who may actually still be homeless, but they are 100% service connected, which means they have a disability payment from the VA that pays them 100%. You can see that with someone who might have a schizophrenia is a good example, but they are actually over income for receiving some of the permanent supportive housing services. In particular, we have a program called HUD-VASH, or Veterans Affairs Supportive Housing, that works with vouchers, and those individuals are, we identify them through our clinical care processes, perhaps inpatient, or they come into the ER, and then they begin to work with the different outreach and care clinicians to then get their paperwork done, and then and hopefully get into housing. I think that's just the kind of beginning of all that.
Others to add about housing?
I would say just from our area, it kind of relates to, there are a couple other questions about funding. And so in Jacksonville, we have a great provider called Ability Housing that is able to run most of our low-income housing in town. And we have kind of a centralized hub in Jacksonville where everyone must go through this housing survey and figure out how high their need is to access housing. And someone who's on the streets with a mental illness, like high needs, will get a higher priority than someone who doesn't meet that criteria, who maybe is staying with has a relative they can stay with temporarily, or people with children are high up on that priority list. And so having a centralized stop because we have so many service providers in the city, to kind of arrange that and sort out who's high priority and who's getting services where has been very helpful in our city. And then also having providers, other providers that have funding for housing. We Sulzbacher's housing first model, so we don't require that someone be sober or stable on their meds before we get them housing, which we have found, there's evidence that suggests that really helps people get sober in the long run, just having a safe place to stay. But I think what we found is that eventually people do need more support still, even after they get sober, after, they've gotten some psychiatric treatment. And so what I really appreciate is we have services for aftercare as well, where they might still get a case manager that can come and check on them. I think that's very important for people with severe mental illness, because it ebbs and flows, and it might be looking good when they graduate your program, and then eventually it comes back. We are run through, we have all these services through state funding. We get some HRSA funding. We just have a whole department that looks for funding everywhere. And since we're grant dependent, some of those grants expire. And so we just constantly have to keep reapplying.
So I would add a little bit of a lens from our community. We also have that similar kind of coordinated access component where there's a centralized assessment. One of the things that our community did when it advocated for us to create the Respite Rehab and Reentry Center is we reached agreement with our coordinated access and single kind of guiding entity that they would prioritize individuals that were ready for discharge from the hospital to home, the 3 to 6 month program where individuals could step down from an acute care psychiatric hospital into a kind of more of a step down or rehab level of care, that when they're ready for discharge, they would immediately go to the top of that list. So it would accelerate not only the opening of a new bed in our residential component, but it would give them almost immediate access to housing upon readiness for discharge, which I think we all thought would be a great way to kind of keep a flow moving. What we also found is it became a great incentive for those individuals to continue ongoing engagement in that care. it helped support that because that was a bit of an incentive for them. The other thing that we've discovered is that, frankly, for a very select population, those individuals with really high need, really complex situations, frankly, most of them recently unsheltered homeless, what we have found is that there's some level of housing that we're just going to need to operate as a part of the mental health system. And so we have a 26 unit SRO building where single room occupancy, where they kind of have a bedroom and a bath and a sink, but kitchen and living room areas are combined downstairs. We're going to break ground in about 60 days on a new 24 unit apartment complex, being funded jointly by the city housing department, the state, as well as one of our managed Medicaid organizations that's operated by the safety net hospital system here in our community. And so thinking about how do we begin to think about housing as a part of our continuum of services as we support individuals kind of into that process, and ultimately, hopefully through that, our goal would be for everyone to live in stable housing in a traditional community setting and not have us as a landlord. But for those individuals that are probably, frankly, I think about them as early ACT participants, having that level of support and, frankly, tolerance, being willing to accommodate a little bit of aberrant behavior and kind of the relapse and remission of early recovery, and being able to weather that and support them through that, we think is critical to their success.
Great. Joe?
Yeah, I'll just add, our community sounds very similar to most of the other panelists. We use a coordinated entry approach and try to match clients to the right type of housing voucher in this community that's more like permanent supportive housing versus rapid rehousing. Permanent supportive housing for patients with severe mental illness is generally the path that we go on because of that wraparound, those wraparound services without an end date. There's not there's one housing facility entity run by Presbyterian Night Shelter called Safe Haven. A lot of communities have safe havens in them. And that here, I believe it's 20 or 30 beds. The turnover in that facility is not very, there's not very many openings very often. So it often is not a ready option for people with severe mental illness, but that is, if you have that kind of option in your community, take full advantage. If there's openings, they're run really well with on-site case management and geared for people with severe mental illness and psychosis. Otherwise, here in Tarrant County, it's based on those supportive services by way of the case manager assigned an organization that they belong to, and then getting the patient or the client connected with those other supportive services.
So turning to the next question, and it's actually one that Laura began to answer about the interpersonal aspect of practitioners interacting with people with psychosis. The next question is, to the panelists is, how do you build or rebuild trust with someone who experiences psychosis during outreach and engagement? Any thoughts?
I think trust is so essential. It's maybe the one of, if not the most important element of outreaching to marginalized, vulnerable populations. And for me, that's the first encounter or encounters is focused on that as the goal, is establishing rapport and trust, because then from there you can move forward. So if that trust gets broken, I think that there's a scale, a spectrum of degree of broken trust can determine how you handle that. If it's a broken trust because of a real or perceived, I wasn't here on time like I said I would be, I'm so sorry. That's one level of broken trust, versus I told you you had your housing voucher next week and it didn't happen. That's a different level of trust. And both of those take different amounts of time and effort to rebuild that trust. And I think the two things that I have seen work time and time again are just time, meeting with people, really being there, being present, and just listening. I think, and I don't mean just listening, but active listening and being present, as cheap as that may sound, and as trendy as that may sound, of just being in the moment, present with them. That is something that they don't experience all that often with people. And it is so important in validating their being, their personhood and dignity. And I think that goes a long way. Those are the ways that I have seen anyway, in initially establishing trust. And in those times when I've broken people's trust, regaining it is by showing up and setting things that I can meet and goals that I can meet. Like I will, if I said I was going to be somewhere and I wasn't, redoing that in the future and following through and making good on that promise. But the two biggest things, being present and listening.
Yeah, I agree. And I think having a team of people that understand that people are going through a lot, I really rely on my peer specialist that can really connect, my case managers that understand the difficulties of the system. I was going to offer too that, a lot of part of severe mental illness is a lack of insight. And there are some really good resources out there. I brought this book to show. This is, I don't know if it shows, I am not sick, I don't need help. I guess it might be backwards, but it's by Xavier Amador. And it's a really great reference in dealing with a loved one or a friend or a patient that has no insight into their illness. I've also used different cognitive behavior therapies for psychosis. One I found helpful was called Treating Psychosis. It has some really quick and easy chapters that can help you deal with dealing with hallucinations. But I really have not found a great tool in completely eradicating delusions that are often harder to treat. And so relying on your trust that you build with your patient and that relationship, that really is what goes a long way.
I'd like to add, as a peer specialist, the non-confrontational aspect of how we approach people who are actively dealing with psychotic symptoms. We don't confront their delusions or their hallucinations or anything. They report to us what they are experiencing, and we tell them how that sounds really hard to deal with. I'm sorry that you're dealing with that right now, in a way that makes them feel validated without reinforcing it. And sometimes they are so used to people telling them that they're crazy, that they're imagining things that can break them out of that mode of no one listens to me long enough for them to open up more about, we get past that and then they can relax and breathe, and then we can talk about the real stuff and what they need. And that's the part of the active listening I think that sometimes gets skipped, is you can't just mirror it back at them without feeling. And then also as a peer specialist, I use very small descriptives of my own recovery journey that are sometimes parallel to what they're dealing with, in a way that makes them feel seen and heard by what they see as someone who is their equal, and that makes them feel even more heard. And those are ways in which, especially in my line of work, because I'm not an actual clinician, so I don't do therapy. I don't do, and I have no control over diagnoses or anything. But what I can do is more in building rapport and building trust and making them feel heard and seen in ways that let the rest of the team then move in and give more support and care that these people need, that maybe they are shutting out from themselves out of lack of trust and things like that.
On the note of best practices, And I want to actually ask a question that Bryson Corbett had asked in the Q&A. You know, like, how do you motivate or nudge someone towards like supportive mental health services? And do you have any tips to share on that?
Well, I want to, I'll speak sort of on the last question and this one. Yeah, I want to refer folks also to last week's presentation, or whatever it was, a month ago, on psychosis, and the presentation discussed a lot of techniques, in particular sort of dialectical behavior therapy approaches and motivational interviewing, ways to a kind of approaches that you can use with really any individual, but a big emphasis, as Angie said, on validating someone with whatever their personhood, as well as that they have needs. You know, I think that as Angie said, you're not going to confront the delusion by definition. That's a belief that they're going to hold despite any evidence to the contrary. So it's kind of a, you know, it's just not on the table. Sometimes that can interfere with what someone does from point A to point B, but you can work with someone to try to identify their common denominators. Like, what is it that you're worried about? What am I worried about? But also, what is it that they're concerned? And so that's why you're there. At the same time, these are folks often who've had a lot of their trust in others broken, and they also have their own condition. And you know, from the clinician's perspective, the patient isn't really obligated to you know, to trust me. Yeah. But I am obligated to be trustworthy to them. And there can be times that, you know, as being human, we will not be able to do everything we said, or the people we're working with will not come through, which is why your team is very important. So sometimes I kind of use this idea of sort of proactive trust building, where I might say that such and such might come up, and it doesn't mean that I don't care. There's just a big world out there, and we're all trying to work together. And I think that's the biggest part, where you know, there's a lot as you try to navigate the healthcare system. There's so many components and so many people, and one person can blow the whole you know, effort that you've been making, and getting someone, you know, almost on the threshold of a house, and then it goes away because of what one person did. So then you have to start again. So the proactive kind of approach can be helpful, at least in getting it back there a little quicker.
Great. Yeah. And just on that note, you know, Laura, you gave a really good segue, you know, to the next question, you know, which is, you know, we have folks, you know, in the audience joining us from like all across the country, if not the world, you know, so every community's makeup is really different. But, you know, how can, like, you know, our audience members like generally go about finding wraparound support for their own work in their own community? Any advice to share, you know, from our panelists on that, about like seeking resources?
Gordon, I probably am not the best person to speak to it from a boots on the ground provider level, but I do just want to say, and there's a couple of questions in the chat that I've been responding to, and I think it's incumbent upon leaders of systems to be challenged to create some of those pathways and some of those dialogues at a formal level and at an organizational level. Dr. Marsh mentioned some of the work groups that she's in. We're in a part of those. You know, I'm fortunate to have been in communities where I got to work with Dr. Marsh and with Joel, and they're tremendous. And they, I think they can probably echo and also appreciate the fact that it is really a responsibility of leadership to figure out how do we create the opportunity for those supports to come together and recognize each other and where we stand in the system, and how do we make it easy for our systems to connect together and with us, so that employees aren't having to manage that on a one-off basis. Because as they do that work, and they do it very well, the next person changes at that organization, and then they have to start all over. So how do we formalize that at a system level? And how do those clinicians, how does Joel go about creating that urgency for people like me to feel accountable and responsible for engaging in those conversations. And I think in addition to the strategies that I'm sure they will all share, I just want to put a plug in for that. Bug the people that have my kind of role and kind of insist that we figure out how to make these systems work better together.
That was extremely well said, Wayne. I think one of the key things from the boots on the ground level is probably doing what you do either in your job description or just naturally, which is advocate, and do that in a way that identifies the gaps. And that can be a challenge in different communities because it can maybe get a little turfy at times and seem like you're trying to, one organization is pointing out the deficit of another organization, and that can be challenging to manage that. But in acknowledging that that's not what's happening, you're just trying to advocate for your patient and getting the right care for them. Getting work groups together has worked really well. A few things that we've done here, born out of really probably the patients that this webinar is focusing on, not exclusively, but people that were high users of all services, emergency and law enforcement, different things, getting together from the different agencies and having a time and space and place to say, hey, these are challenges that we have accessing the care for Mr. So-and-so. And it kind of deflects some of that unintended accidental finger wagging from one organization to the other and refocuses it on just trying to get your patient the care that they need. And that care might not be available in the community, or you say, hey, I need this service and I am just not finding it. And somebody says, oh my gosh, yeah, there's this service down the street that does X, Y, and Z, and it sounds like that'd be a great fit. And you didn't even know about it. And it's always humbling what services are available that I don't know about, whether, I'd like to think I don't have my head in the sand, but things are just, like Wayne said, they change, they move, and there's different things that happen. And I think also something I've just been reminded of recently is just because something was tried and it didn't work last year doesn't mean that you can't try and that it won't work this year. And that's just being that advocate and being hitting the refresh button. And honestly, I'm kind of stuck on this idea of imagining and reimagining, and not just thinking outside the box, but like obliterating the idea of a box and approach it, the notion of how to get something to work like a kid approaches a painting or a fort in the living room. Like, just this is where we are. This is what my patient, my client needs, and here's what we have. How help me, as a community, what can we do? So that those aren't necessarily maybe real step 1, 2, 3 kind of suggestions, but it can be done, and it is this whole thing, this whole endeavor of helping, I think, people in marginalized communities is definitely more of a marathon in the long term, the long game. So hopefully that helped.
Very much so. So an anonymous attendee, I pointed out that we're all sitting in cities here. And Jacksonville, Dallas, Fort Worth, and then, 3 of us over down in Houston. So would any of what your answers given around like resources for wraparound support be different for an audience member sitting in a rural area? And if so, how do they go about looking for resources in those settings? Angela, you want to start?
Specifically for peer support, there's a national mental health support you can get through NAMI, the National Alliance for Mental Illness. They have support groups and classes and things for all kinds of family members and friends, and then also consumers. You can get support that way, and that is your first step in a more rural area. attending a support group through them. A lot of them are available virtually since the pandemic. So even if you're 30 miles away, you can still attend on your phone. There are people like me running those groups who will have the resources for your area because they will be talking with consumers every day who maybe are telling something they found. That would be your go-to for resources in the smaller communities, at least as far as peer support and finding community resources is and has been in my experience living in South Dakota, Iowa, Nebraska, and Texas. Across the board, NAMI was my go-to place to find the local access to resources.
I agree with NAMI, and theoretically, that's what 988 was set up for. You call 988 and you can get connected to a local resource hub. So hopefully as that grows and improves, you could potentially call that number and get connected to better resources in your area. But I do think that the pandemic at least brought us more availability of telehealth. So specifically, if you want a psychiatrist to see your patient, you might be able to just hold up your phone and get a telehealth visit with them. And that could be someone from a city in your state, you know, that is licensed in your state, and they might be familiar with street psychiatry and the unpredictability of it, that they might not be able to schedule an appointment, but be available if you call.
And so this is great, you know, especially because like you both traverse like, you know, kind of like lived in rural areas. There are like two other common questions that have come up in the Q&A box. You know, one that came from Block Lamb and a similar about law enforcement involvement, and a similar question from Ellen Y about calling 911 first rather than, you know, 988 or another number. What's your take about involving law enforcement and from within your capacities?
So I'll just talk a little bit about at least our system. We have a pretty broad set of collaboration with law enforcement. And I think about it kind of on a continuum of anything else, right? So we have co-responder teams where we have mental health clinicians that ride along and dispatch with law enforcement. We have tablets in a few hundred patrol cars in Harris County where they can connect with my clinician and we'll do a crisis assessment remotely. We have alternative response teams that go out in lieu of law enforcement from a 911 dispatch center. And then we have our regular MCOT teams. And I think it isn't a question of should you or shouldn't you. I think we've got to get to a place of what is the right response given the context. And unfortunately, we're not there yet. What response you get will often depend upon who you call or how you engage the system. But I think it's there. I mean, I think we're getting there. I think there's a potential of it closer than I've ever seen. To your point, 988 is a tremendous resource. We answer the 988 calls for, thus far, we've answered about half the 988 calls for the state of Texas. We cover about a third of the population here in our state as a 988 center, my agency does. And so that's certainly a way to get teams dispatched and get a crisis response out. We're fortunate in Texas in that we invested in a crisis response system many years ago, so we have some infrastructure other states might not have. But I think it's critical to not alienate and get into an either or. I think there are many scenarios where, frankly, a mental health clinician is not going to respond, certainly not alone. And so you're going to need an element of that police response. So how do you partner with them? How do you help support their training? How do you create a well-informed police department and help them think through that response? If you go and look, we had a policing reform task force here in Houston that did, I think, a really nice job of creating recommendations around a whole section on crisis intervention recommendations for the police department to help broaden their kinds of response and their thinking around that. That's out there publicly. If you look up Houston Policing Reform Task Force, you'll see that report out there. But I don't want to get into kind of a false dichotomy of should you or shouldn't you. I think it's when is best to and when is best not to, and how do you build the kinds of infrastructure you need to not always rely upon law enforcement as that response mechanism.
To add on to what Wayne and Harrison is doing, our community, starting with the homeless response system and really trying to develop a a better method back in the around 2012, started bringing all the different stakeholders together. And prior to that time, the homeless services really were psychosocial only and relatively not involving healthcare. And now there's psychosocial and law enforcement and medical, et cetera. And and it keeps growing and growing as to who's involved. As Joel says, you don't always know every resource, but over time, you really have to keep building that. And it is an ongoing effort to get everyone in the community together so they can work together. Joel also mentioned there's that tendency to have finger wagging, that someone's doing the wrong thing or that other group's doing the wrong thing or they're not pulling their weight. And as a leader of one of the systems, we have to really take that approach of, we're all here, we're all doing the best we can. And what else can we do together? Again, the tendency is for groups or agencies to say it's the patient's problem, when often it is our system working together and how we need to do that differently. And there's nothing worse I have found than if I start talking to a group that's been working with a veteran or a person out in the community and then making suggestions of all these things that they've already tried. I mean, what my role is to say is what can I do as part of the system to help? And I think if you're boots on the ground, it's important for you also to think about what the system's doing, because you're out there doing your work and you're doing kind of what's right in front of your nose. And sometimes you have to step back and say, who else needs to be here? If that patient has a psychiatrist and has someone else who's over at another part of town doing something, get them all together for a phone call and see what everyone can do together. So you can initiate these kinds of things to help that system work better together.
So shifting gears a little bit, the substance use has been mentioned earlier in this webinar already. And I see a question from Cecilia Bates about harm reduction, and one I believe from April Schoenhardt about whether that compromises someone's housing experience. So can you all elaborate a bit on how, whether there's any sort of tailoring in service provision when it comes to someone with substance use and psychosis, please.
I will, first of all,
Thanks.
Housing First says, go ahead and help that person get housing. It's the fundamental thing. That's the way you end homelessness, is have a house. And there's lots of data showing that if you can meet those basic needs, that helps people go on to the next step. As a physician, I find if I take care of people's medical needs, again, that helps them, stay engaged with me and work with me. The substance use is challenging, and even psychosis, and the combination can lead people to become agitated or destructive, harm others, and so that has to be addressed, with the ways that we address that, and to remind the folks who are, whether it's landlords or others, to make sure that we know about that. And then, we can. It's important to reinforce the positive behaviors, and I know that one of the programs that's really well developed by Harris Center involves the assisted treatment, and with the courts. I think Anna talked about that as well. So sometimes that's a really wonderful way to help people get engaged in care, is to add that additional layer of the courts.
In my experience, in working with people with psychotic disorders and substance use, it kind of depends on the substance a lot of times, as well as how the psychotic disorder manifests. If there's going to be destruction to the property, then that's a challenge. probably a lot of you have had patients that rip the sheetrock off the wall because they're trying to get to whatever they think believe is behind the sheetrock. That's going to cause obviously some problems with the landlords, and that's a time frame that is challenging. And if they're not willing to engage in treatment, then but they're still competent to make those decisions, then that's a challenge. That's just a tough spot, and oftentimes ends in unfortunate eviction, kind of understandably from the landlord's perspective. However, with other types of psychotic disorders and substances, alcohol maybe, where maybe some of that more aggressive behavior isn't, or I shouldn't say aggressive, but destructive behavior or aggressive towards other tenants isn't as profound, but there's still those two co-occurring things of psychotic disorder and substance use that is creating some health risks, some problems, some degradation of the well-being of the person. That's another kind of approach and issue, and those I have found to be, I don't know about easier to work with, but less fear maybe of eviction, and trying to, using the home as a reinforcing the home as a treatment base, a place of safety and security. And sometimes in terms of what you can do, this is where we lean heavily on partners with our lead COC agencies, of trying to have discussions with the landlord to help educate them on what is being done, what actions are being taken by the professionals in this community and in this realm of behavioral health issue, and that things are being done. A lot of times, or I should say sometimes, landlords will be understanding and will give more leniency. So there isn't, I don't think there's not an easy, I don't know of an easy answer that always gets the result that we want for ourselves and our clients. But being active and advocating and going to the patients and frequently, I think is some of the big things that can be helpful.
Thanks, Lorenzo. So with our remaining time, I like to do 2 round robins. One is to, for each of our panelists to tell the audience, what are the training or other resource or books or other resources you'd recommend? Because, as Celeste Espinoza said, this group that we're talking about today, people with psychosis, they're special and they arguably have higher needs. And I'm quoting Celeste here. So for each of you, what are some of the resources, again, that you would point our audience to if they want to learn more about, how to care for, again, folks with psychosis? Laura, would you like to start?
Anna was getting ready and I can follow up after her.
Oh, okay. Anna, go ahead.
I was just going to second NAMI, National Alliance on Mental Illness. They have a great website that has all kinds of free resources, but then also your local NAMI chapter can help get you connected to peer groups or family groups. Personally, I do really like Xavier Amador's book about the lack of insight or anosognosia that people with severe mental illness face. And then Surviving Schizophrenia is another really great book that I'm sure every psychiatrist recommends to their patients and families and friends. Those are definitely 2 great resources I like.
Second, both Amador's book. He has a brother with schizophrenia, and it's excellent. It really helps you be in the shoes of both the person who has schizophrenia as well as the family member. And if you're AKA the person who's trying to work with this individual. NAMI has some wonderful programs on just general education, but also some that are more experiential about learning, in their coursework from individuals who have lived experience and who can talk to you more about what it's like as family. And, of course, not every individual who's homeless, you can find their family, but if you can, sometimes that can be useful, and you're going to need to perhaps navigate how they work with you and that individual. I will second Surviving Schizophrenia, and which is by Fuller Torrey, who also has a sister who has had schizophrenia. So all these folks really were motivated and know what it's like to have that condition and to try to help people when it who can be challenging to help because of the symptoms that they have, which that doesn't mean they're being difficult. It is their symptoms. And I think often people will think that that person is being difficult, or that ambivalence is in, someone had mentioned also this experience of trauma, which can be something that, again, whether it's broken trust or just having had some other event occur or being held down and given medicines. These are things that people that can make it difficult for someone to get back involved in care. There's another organization called SARDA, SARDAA, and that's for or Schizophrenia Alliance, and that can have it's a self-help group, but there's also another group along with it that can provide information on working with individuals who have schizophrenia. So all of these resources are pretty good.
From a book perspective, I really like J.S. Levy, his books. On one of them is the one, if I had to pick, actually it's what he says. If he recommends, if you're only going to read one of his books, it's called Pre-Treatment Guide for Homeless Outreach and Housing First. He's a social worker, a clinical social worker by training, and his books are written with case studies as examples, and it's really, I think I have all my learners read that, and it really helps fill in a lot of gaps, and I think give some ideas and hope, because he doesn't give just simple, easy, slam dunk examples. There's really some good examples, and he has his own website, J as in the first name, J-A-Y, JSLevy, LEVY.com. You can get his books in other places as well, but to get kind of an overview.
Angela, Wayne, great. Any resource to offer?
Yeah, again, the NAMI. I can't say enough about the grassroots organization NAMI. National Alliance on Mental Illness is great. They have classes for family of veterans who have specific mental health needs that maybe families are lost trying to help their loved ones. And then there's their suicide prevention programs, hundreds of different educational opportunities through their website. As for books that I personally can recommend, specifically for this demographic, there's a book called The Psychosis and Mental Health Recovery Workbook. I think that, hold on. Yeah, Jennifer Gerlach, Gerlach. And it's got ACT, DBT, and recovery-oriented CBT skills in it. And it's really good as far as I provide a lot of self-help type workbook pages with our clients, because I don't do the actual therapy, but I might have coping skills papers I can hand out from DBT or elsewhere. Another one that works well that also covers like the addiction aspect is the Mental Health Toolkit. And that's by Linda Hill. And that is, again, like a workbook, and it's got like DBT and CBT, complex PTSD, and then addiction and anxiety skills and tools and workbook pages that people can work on, building up their ability to have interpersonal communication skills built up, or maybe ways of regulating their emotions and things as they're working through the process of currently having active symptoms as far as those with psychotic disorders. Other than that, yeah, it's my wish for everyone is that they find their own path to recovery, whatever recovery looks like for them. And so whatever ways that we can support them in getting to the life they want to lead, I am all for it. So I just, again, want to say thank you for letting me participate today.
Yeah, so I would say that our hospital to home program was based largely upon information that was found in SAMHSA's TIBS publication around behavioral health for individuals who are experiencing homelessness. So I think there's some nice resource in there. But I would also suggest that we think about leveraging, I think there's, as I see it, almost 2,000 people, participants on this, and there's lots of people with lots of great ideas. And some communities may not have all the things that we've described in Harris County, but they've got some stuff that we don't have, right? Community pressures and priorities have caused all of us to develop our system of care and support in different ways with different priorities. And so I don't think we do enough shared learning. Certainly there's a lot of emphasis on learning collaboratives these days, but I don't know that we always collaboratively learn. And so I think there's lots of opportunity for that and lots of expertise that exists in these and similar rooms where we can learn from real world efforts at making improvements in our system of care.
So Angela and Wayne started to close us out, but I was gonna ask like each of our panelists to, if you were to give some final words to our audience members, like what would you say? What are some of your, I think maybe let's say top 3 bullet points from our discussion today?
Nobody wants to go first. That's a tough question. Trying to synthesize all this down to 3 points is not an easy thing.
Oh no, you don't have to. It could be less. It could be more.
You can do it, Wayne.
I'm going to give it a shot. I'll take a stab at it. Give my colleagues a chance to think about it. But it only raises my expectation for their answers. So I would say first, and this is probably true to me no matter what the topic is, it's collaborate, collaborate, collaborate. Right? Like we cannot do this. In a way that's isolated. We can't do it alone. No system can make all the things that need to happen. And so I think there's also a theme of how do we begin to come together to think about system level transformation? How do we create the conversation in the space in the room to talk through it? Dr. Marsh mentioned a work group that, it met every 2 weeks for almost 2 years. And it got 40 people to voluntarily show up every 2 weeks in the middle of a pandemic. To talk about how do we address this problem and what do we need in our community to do it. So I think if there's leadership there, people will join and will engage and have experts like Dr. Marsh show up and educate all of us. And then the other part is I think not losing sight of the progress that's being made, right? I think it's easy to kind of get almost overwhelmed by it. There's so much need, but we're talking about things and levels of care and interventions and supports that probably most of us couldn't even fathom 10 years ago, right? So we are making progress. It's hard to see it sometimes, and especially those people like Angela and Joel and Dr. Marsh and Dr. Turner, I'm sure, who are kind of boots on the ground and see it literally every day and are trying to support people every day through this. But if you take a half a step back, I think you can see the tremendous progress, and it might be important to even celebrate a little bit of that progress.
Yeah, and I really like how Joel said it's a marathon, not a sprint. These things take a long time. It took them a long time to get to you, and it's going to take them a long time to get to whatever their next step will be. But if you can just be with them as much as you can, I think it can only help.
I'll add also echo everyone, but also be as proactive as possible. I think one of the things our work group does as a system is think about what's coming down and what can we do in advance. It's where Wayne has been amazing in getting a lot of these resources pulled together. But I think at the individual level with the person you're working with, to let them know this can take a long time. And, I'm here for you. And if I'm not here, I've got my team here. And, and you may not be ready to be in a house in 1 year, and that's okay with me. So the time is both how we work together and collaborate. That can take time, takes a lot of energy and willingness to speak up. and poke your nose in and, someone and know that validate in the same way that you do with your individual and then also what you do as a group.
Yeah, and I say transparency and integrity, being open and honest is key. The transparency, if you know that there's possible sideways ways things can go, be open and honest with your clients right from the beginning that those are possible. I found that as long as they know what's going on behind the scenes, even if they aren't getting the answers they want, just kind of knowing what's happening, that they don't have that information directly, can ease them to a point where they can accept a longer wait to getting to their goal. And then for each of clinicians of various sorts or professionals watching here, join your local associations if it's a local group of LPCs or LCDCs or your local peer specialists, so that you have that access to local resources through them, that you can share information that way to help support your clients better.
I would say building on, man, all of these are great, and I'm probably just recycling them, but staying fresh with ideas and imagination, and reimagining, not getting stuck in the way that because we do it this way, that's how it has to be done, or that's the only right way, but really approaching issues and problems and challenges with imagination, like a childlike imagination. Listening, I said that earlier, I just find that is just magic. When you stop talking and let your client, your patient listen, or let them talk, and you truly listen without judgment, that goes so far. I really feel like that is restorative, that is dignifying, that is respectful, and that goes, that gets a lot of bonus points, if we're going to use bonus points. And then lastly, and hopefully you'll look into this more, but this idea of accompaniment. There's a Haitian word that I can't say, but it means accompaniment, but the way the Haitians, I think it's true to Haiti and not just French, but it means kind of a bridge walker. It means being with somebody, journeying alongside them, not necessarily telling them where to go, but just being there. And if they need you to tell them where to go, then you can help them. But really accompanying people and at times your organization or your team, but this idea of accompaniment, I feel is really important.
If anything, I think the 5 of you deserve lots of bonus points for sharing all your insights and, in closing us out with the reflections. And yes, we really appreciate hearing from you today, Laura, Anna, Joel, Angela, and Wayne. We have 3 minutes left, so I want to, give the floor back to Jen to close us out. Yeah. So Jen, go ahead.
Great. Thank you so much. And I just want to echo how appreciative we are of the panel for sharing your expertise today. This was just such a rich discussion. I love the resources that you offered. We're going to gather those up, make sure we get those on the event page for others viewing this. And thank you so much to Gordon for pulling together this fantastic panel and expert moderation of this great discussion. So we appreciate that. And we appreciate everybody attending today. So there is a link in the chat and a QR code here for a short evaluation. You'll be redirected to a certificate of participation upon completing that. Sometimes our community is so excited that we accidentally crash the website for a couple minutes right at the end of a webinar. So if at first you don't succeed, do try again and reach out to us. Reach out to our team if you have any trouble with the survey or the certificate or just any questions that we couldn't get to. I so appreciated the audience's feedback, great questions. Thanks, everything that we received through the Q&A today. So we hope that you will keep joining us in the future for future events and reach out if we can do anything. So again, thank you to all attendees and thank you so much to our great panel. Take care.